Good morning everyone. Today we are going to see the topic central sleep apnea. It is a part of a whole sleep apnea which is usually missed. Myself Dr. S. Tamilmani, I am a senior resident from the Department of Respiratory Medicine, Chettinad Hospital Research Institute, Kelambakam. So the learning objectives for this topic is, first of all, we have to define what is central sleep apnea and able to classify its major subtypes based on the partial pressure of carbon dioxide levels. So basically there are two types. One is hypocapnic, another is hypercapnic. So we have to see the differences of each. Next objective is explain the pathophysiological mechanism of central sleep apnea, including the concept of what is the apneic threshold and high loop gain in hypocapnic central sleep apnea and chronic hypoventilation in hypercapnic central sleep apnea. The third objective will be describe the characteristics, feature and polysomnographic pattern of key hypocapnic syndromes. Syndrome per se is a collection of disorders or collection of pathologies such as idiopathic central sleep apnea, chain stroke breathing, associated central sleep apnea and complex sleep apnea. The fourth objective is identify the common causes of hypercapnic central sleep apnea, and we should be able to distinguishing them between central drive failure, that is the patient who is unable to breathe, and pump failure, the patient who can't breathe. The final objective will be recognize the clinical presentation of different CSA syndromes through case studies. So we have a different case scenarios or studies for each conditions, integrating the patient history and polysomnography findings to arrive at a diagnosis. Coming to the introduction part. So first we will see what is the definition of central sleep apnea. Central sleep apnea is a cessation in airflow, that is the flow will be cessations or stopped of 10 seconds or longer and associated with an absence of respiratory effort. So here the two things are more important. One is cessation in airflow, another one is absence of respiratory effort. Next, the prevalence. So it is not common as compared to obstructive sleep apnea, but accounting for about 5% to 15% of all sleep apnea cases together. Since the two factors have increased the number of central sleep apnea patients, the one factor is there has been an increased recognition of sleep disordered breathing in patients with congestive heart failure. So there are a lot of cardiologists who are now coming up and sending their patients for a evaluation to look for any other sleep related disorders. So we now we see a lot of congestive heart failures who are associated with central sleep apnea. The next is recently there has been a more aggressive use of opiates to control the pain, which precipitates the central sleep apnea. In this picture you can see there are three graphs. One is a central hypopnea, that is the flow falls in the proportion to the respiratory effect. The next one is obstructive hypopnea. There is a flow limitation and a decreased flow even though respiratory effort stays the same. So there is only the obstruction part which is predominant. And mixed hypopnea, there is a fall in respiratory effort as a part of central sleep apnea. So which is proportionately greater because of the obstruction component present in the patient. So it is kind of both. Coming to the classification, the first group will be discussing is hypocapnic. That is, either the patient will be in the normal daytime PCO2 level or low daytime PCO2 level. Among this category, there are 4 conditions. One is idiopathic central sleep apnea. We call it as primary sleep apnea. Chain stroke breathing associated central sleep apnea. Third one is high altitude periodic breathing. We say high altitude periodic breathing. The fourth one is complex sleep apnea. The next group of disorders will be hypercapnic. In this, the CO2 will be elevated. In this, there are 2 broader category. One is won't breathe and another one is can't breathe. The won't breathe group will have 3 conditions. One is central hypoventilation syndrome. Second one is medication induced central sleep apnea. Third one is obesity hypoventilation syndrome. The next will be can't breathe. In this patient, the can't breathe category, there will be restriction in chest movements or there will be a neuromuscular disorders which lead to central sleep apnea. Pathophysiology. The concept of apneic threshold is very important to understand the pathophysiology of central sleep apnea. During a NREM sleep, that is non-rapid eye movement sleep, breathing is entirely, during NREM sleep, breathing is entirely driven by chemical signals, primarily the level of carbon dioxide in the blood. So, this blood parameter, carbon dioxide, is more important to maintain the breathing. In what happens is apneic threshold is, the apneic threshold is a specific cutoff point, that is PCA2 level, when below which the breathing will stop. So, when the patient is sleeping, usually there will be an increase in partial pressure of carbon dioxide. But what happens is, in some cases, for susceptible individual, there will be a small drop in partial pressure of carbon dioxide because of hyperventilation or because of an obstruction or because of any central conditions, due to which there will be a drop in carbon dioxide level from sleeping carbon dioxide level, which pushes below the apneic threshold, causing a central apnea the moment they drift back to sleep. So, the difference is more important. The smaller the difference between sleeping carbon dioxide level and apneic threshold, higher the risk of central sleep apnea. In this, you can see the patient before a pre-hyperventilation. Okay. Next, the patient is going for a hyperventilation. Then what happened? The carbon dioxide level falls below the apneic threshold level. After that, what happens? There will be a cessation of breathing. So, this lead to a cycle. So, central sleep apnea starts. Next, the concept will be ventilatory control and loop gain. So, the concept of loop gain is, a loop gain means the system is stable and makes a smooth adjustment, like a thermostat present in a refrigerator. So, when the temperature is high, it decreases the AC temperature, and when it is low, it automatically adjusts the temperature inside a refrigerator. The same mechanism our body has, that is we call as loop gain. So, a high loop gain means the system is very unstable and the system is prone for overreacting. Okay. The next is controller gain. Is a high controller gain, means the brain has a very strong control of respiration. So, almost an exaggerated response, telling the body that at this time you have to breathe more or less, even with the minute changes in carbon dioxide levels. The next concept is plant gain. A high plant gain means the lungs are very efficient at blowing off carbon dioxide. So in this, what happens is our respiratory muscles are compensating and working more to eliminate the carbon dioxide. So a small increase in ventilation causes a large drop in carbon dioxide. Okay. The next point will be the formula for instability. Why does the instability occurs? So the whole loop gain is basically the controller gain and plant gain. The overall stability is a product of brain's sensitivity, that is control, and lungs efficiency, that is response. If either of these two is high, the loop gain is high and can exceed a value of more than 1, making the entire system unstable. In hypocapnic central sleep apnea, the primary problem is an excessively high controller gain. So the brain is very high sensitive for a small changes in carbon dioxide level. This is a table I have taken from a book, Principles and Practice of Sleep Medicine. The author is Douglas. So it demonstrates that what happens to the sleep when the patient is awake, when the patient in NREM sleep, and what happens to the REM sleep. So the wakefulness drive. Why we are awake in the morning? Because our brain is constantly giving the signals that we should be awake, we should not feel sleepy. So this will be present in a wakefulness. But on the other hand, when we are sleeping, the cycle will be NREM and REM cycles. Then central chemoreceptors. What is this central chemoreceptors? It's the adjustment of the circulation and respiration based on the pH and carbon dioxide level. That will be completely intact in a wake person, but it will be reduced in an NREM stage of sleep and it will be very much reduced in REM sleep. Then peripheral chemoreceptors, that is sensation for oxygen, carbon dioxide and H plus ion. What will happen is in a wake person this will be intact, and in an NREM person it will be reduced, and REM person it will be very reduced. Apneic threshold. What does this apneic threshold mean? It is a cutoff point, the below which the CO2 level fall, the patient will feel an apnea. Usually the central sleep apnea will occur in NREM sleep phase. So the apneic threshold is a concept of NREM sleep. The last point is behavioral and other non-voluntary control center influences. So what does it mean? We can change the behavior and other non-voluntary control system. Like if we touch a hot object, we suddenly remove our hand. So that is the non-voluntary control. So it will be present in wake. In NREM sleep it is completely absent, and in REM sleep the periods of reduced tidal volume during phasic REM sleep often associated with burst of eye movements. So basically this is a summary of what does the sleep on ventilatory control. Now we are going into the individual types of central sleep apnea. The first one is idiopathic central sleep apnea. We also called it as primary central sleep apnea. The etiology will be, the cause is completely unknown as the definition says, but there is a representing a primary instability in respiratory control. That is, the problem is with the respiratory control. Okay. The next is we will see the mechanism. So why does it happen? These patients exhibit a high ventilatory sensitivity to carbon dioxide level. So high controller gain and sleep instability. The transition between sleep and wake is particularly vulnerable. So what does it happen? The series of events. The first is the patient has a brief arousal from sleep due to any stimulus. Then this arousal trigger transit a over breathing period. Then this hyperapnea rapidly drives PaCO2 below the apneic threshold. So there will be CO2 washout. As the patient attempts to return to the sleep and the wakefulness drive disappears, a central sleep apnea occurs. The apnea causes carbon dioxide to rise, which eventually stimulates breathing again, often leading to another arousal and repeating the same cycle. What will be the polysomnography finding in a idiopathic central sleep apnea? In idiopathic central sleep apnea, the polysomnographic findings will be frequent central sleep apnea. Okay. Then the timing of event is this central sleep apnea most commonly occur during NREM sleep. As I discussed earlier, NREM sleep is the most common phase of the sleep where central sleep apnea occurs, especially in the stage 1 and 2, and may follow an arousal from a non-respiratory stimuli. The diagnosis will be, it is generally accepted that the central sleep apnea must be account for more than 50% of the total respiratory events recorded during the sleep study. In this graph, you can see the patient with an idiopathic central sleep apnea. The central sleep apnea will be followed by a hyperventilation. Now we are going to the second type of central sleep apnea, that is chain stroke breathing associated central sleep apnea. The pattern is a cyclic crescendo and decrescendo pattern. So crescendo and decrescendo pattern, that is waxing and waxing and waning pattern of breathing followed by a central sleep apnea. In idiopathic, what we saw, it was hyperventilation. In this, it is there will be gradual increase in breathing, then decrease in breathing followed by a central sleep apnea, again increase in breathing, decrease in breathing followed by a central sleep apnea. The primary association is most commonly it is seen with congestive heart failure patients, particularly systolic dysfunction, where the heart's pumping function is weak. So what is the pathophysiology? An apnea causes CO2 to build up in the lungs and the blood. The brain chemoreceptors finally senses the high carbon dioxide, but as the patient is a congestive heart failure, there will be a circulatory delay. The signal is significantly late. By the time the brain reacts, the carbon dioxide is already very high. The brain already highly sensitive, so high gain overreacts with the period of intense deep breathing, that is hyperapnea. This hyperapnea continues for too long because the brain has not yet received the signal that the CO2 levels are already dropping. So in this, what happened is the heart is the major problem. Because of it is failure, these signals won't reach the brain on time. This prolonged hyperapnea rapidly blows off too much of carbon dioxide, driving carbon dioxide well below the apneic threshold. As the low carbon dioxide blood slowly makes its way back to the brain, the drive to breathe ceases and another central apnea begins. The long cycle length, often 45 to 90 seconds, is a hallmark of this condition and directly related to circulation time. So caused by a poor heart function. So poor heart function is the major culprit for this condition. In polysomnography, what we will see is a crescendo decrescendo breathing pattern, the hallmark, which is noticeable, a waxing and a waning of tidal volume in respiration, where breathing gradually increases then gradually decreases. The longer cycle length, unlike typical central sleep apnea, chain stroke respiration has a cycle length of 40 seconds or more. This is very important. Chain stroke respiration will have a cycle length of 40 seconds or more from the onset of one apnea to the next apnea. Central apneas and hypopneas, repetitive periods of reduced or apneas or hypopneas are observed with no persistent thoracic or abdominal muscle movement. This is a polysomnographic graph of chain stroke breathing associated central sleep apnea. You can see the crescendo and a decrescendo pattern of breathing. Following that, there will be a central sleep apnea. Now you are going to the third condition in hypocapnic type of central sleep apnea, that is high altitude periodic breathing, a normal physiological response to low oxygen level. Usually it is a physiological response. So when we are descending above the sea level, either climbing a mountain or going up above 4,000 meter, so we faces low oxygen levels. What does the body reacts to it? This is a classic conflict of interest for a body's control system. Powerful drive to get more oxygen stimulates constant hyperventilation. So the oxygen is very less in the body. So what it happens, our body makes a response. We should breathe more so that we will get more oxygen. This hyperventilation is very effective, and what does it do? It blow off a large amount of carbon dioxide. During sleep, when the wakefulness drive is gone, the low carbon dioxide level easily falls below the apneic threshold as discussed earlier. This apneic threshold is very important. Below that, there will be causing a central sleep apneas. This results in fragmented sleep and complaints of poor sleep quality or a feeling of suffocation. So acclimatization over several days helps to stabilize breathing. So we say that the patient should go above the climbing by a slow phase, that is, he should have acclimatization for a particular height, then he should climb again, by acclimatization of the breathing. In polysomnography, there will be a recurrent central apneas primarily during NREM sleep at a frequency of more than 5 per hour. The cycle length should be 12 to 14 seconds. So these parameters are very important when we have to diagnose this condition. Now coming to the concept of complex sleep apnea. Basically it is a mixed type. So the definition, the emergence or persistence of a central apneas in a patient with predominantly obstructive sleep apnea. So the patient will be presenting to you with an obstructive sleep apnea. Then we will be initiating a patient on PAP therapy, that is positive airway pressure therapy, which resolves the obstruction. Okay. So in the mixed apnea, we treat first the obstructive sleep apnea. When the treatment is going on after initiation of positive airway pressure therapy, the obstruction part will be relieved. Then we will be able to identify the central apneas. The mechanism is, it is thought that the PAP therapy unmasks, that is open up the underlying instability in ventilatory control. So the ventilatory control is also a problem here, that was hidden by a airway obstruction. So by eliminating the airway obstruction, the patient can now hyperventilate much more effectively in response to transient increase in respiratory drive. This newly effective hyperventilation drives carbon dioxide below the apneic threshold, causing a central apnea. The primary issues at the baseline. In many cases, idiopathic complex sleep apnea, this resolves over a weeks to month after consistent use with CPAP therapy. A patient, this is a polysomnography of a patient with complex sleep apnea. On the top, the patient is in a stage R on a CPAP of 10 centimeter with stable breathing. So what happens? After the correction with the CPAP, there will be a central sleep apneas. Pathophysiology of hypercapnic central sleep apnea. So the hypocapnic central sleep apnea part is completed. Now we are moving to the hypercapnic central sleep apnea. So what does our body, how does our body react to a high level of carbon dioxide and how it is associated with the sleeping pattern? So in this, the broad categories are won't breathe and can't breathe. So what are these conditions? Basically we see the core issue is not with the ventilatory instability, but there is a chronic hypoventilation. So the body's overall minute ventilation is too low to maintain a normal carbon dioxide levels. This leads to elevated carbon dioxide and low oxygen, which significantly worsen during the sleep, and the symptoms include morning headache, cognitive slowing and eventually a right heart failure. So our decision making, our productivity, our quality of life, everything will be affected. Central sleep apnea are present but are a part of a broader pattern of dangerously shallow breathing or an abnormally slow respiratory rate. So usually it occurs in a REM sleep. So worsen the hypoventilation. So we saw the hypocapnic central sleep apnea is a condition in NREM sleep. Hypercapnia we see in a REM sleep. Now moving to the individual types of hypercapnic central sleep apnea. The first one is congenital central hypoventilation syndrome, which is also called as Ondine's curse. It is a rare genetic disorder caused by mutation in PHOX2B gene. Usually it happens in 1 per 2 lakh live birth. The mechanism is a profound failure of the autonomic control of breathing, especially during sleep. So the ventilatory control is intact but the autonomic control is broken. So when we are awake, we know, we consciously breathe, we inhale, we exhale. But when we are asleep, this breathing is completely taken by the autonomic system. But in this condition, this autonomic system is completely disrupted. So the patient won't be able to breathe. So patients have a severely blunted or absent response to high carbon dioxide and low oxygen level. So their body does not recognize these chemical signals. They effectively forget to breathe. That is, the patient is literally forget to breathe. when they fall asleep. This disorders present at birth and requires a lifelong ventilatory support during the sleep, usually via a ventilator and a tracheostomy. So the survival for this patient is very difficult. You can see a polysomnography of a patient with congenital central hypoventilation syndrome. In this you can see on the left side when the patient is completely awake, but on the right side the patient is completely asleep. Next is acquired central hypoventilation. So hypoventilation associated with the damage to the brain stem, that is the root is affected. The cause is direct or indirect damage to the brain stem's respiratory control, basically located in pons and medulla. The etiologies are brain stem stroke, infarction or hemorrhage, tumors compressing the brain stem, infection, severe trauma to the head and neck, any neurodegenerative diseases affecting the brain stem. So these are the common etiologies for these conditions. The mechanism is the structural damage impairs the brain's ability to sense the carbon dioxide and oxygen levels, or to generate and transmit the rhythmic signals to the respiratory muscles. So when the carbon dioxide level is high or O2 level is low, the baroreceptors will be present in the carotid body. It sends the signals to the brain. But what happens? These signals are interrupted. So what happens? The brain won't give signal to breathe. Okay. So basically it is a hypoventilation, but the presentation can be stable at first, manifesting only during the sleep, but can progress to full-time respiratory failure. So the awake CO2 will also be elevated. Next condition is medication induced central sleep apnea. Nowadays there is a medication induced central sleep apnea. In recent times there is high usage of central nervous system depressant medications, most notably opioids. Examples are morphine, oxycodone, methadone, fentanyl. These are being used to depress the central nervous system. The effect is magnified when combined with other sedatives like benzodiazepines. So we are suppressing the central nervous system. What does these opioids do? Opioids are potent respiratory depressants. So they act directly on receptors in the brainstem. So they decrease the chemoreceptor sensitivity. So a higher level of carbon dioxide will also be get unnoticed. Then slow respiratory rate. They reduce the intrinsic rate of brain's respiratory pacemaker. So respiration rate will be decreased. Then disrupt rhythm. So they can cause ataxic breathing. So breathing will be affected. This leads to a combination of central apneas, obstructive apneas due to muscle relaxation and a hypoventilation. So this is a polysomnography picture showing on the left side by a patient on methadone, that is 6 to 7 breath. You can see the patient's breathing is severely decreased. A 60-second tracing is shown. On the right side there is a variation in flow, there is a variation in flow amplitude. The patient has an ataxic breathing. This is another polysomnography picture of a patient on fentanyl patch for pain control. Neuromuscular and chest wall disorders. So basically these patients won't able to breathe or can't able to breathe. So neuromuscular chest wall disorders. These category of the patients are can't breathe syndromes. So, conditions which weakens the respiratory muscle and mechanically restrict the movement of chest walls, leading to a pump failure. So, there won't be inspiration and expiration. Examples are any neuromuscular conditions like amyotrophic lateral sclerosis, muscular dystrophy, myasthenia gravis, post-polio syndrome. Chest wall disorders like severe kyphoscoliosis, fibrothorax, thoracoplastic and thoracic cage injury. So, these conditions the muscle power is reduced, these conditions the chest movement is restricted. So, brain sends the signal to the brain. So, the signal is intact here, but the central drive is often increased as the brain tries desperately to compensate, but the respiratory pump is too weak and there is a restricted chest movement to generate adequate tidal volume. So, this creates a vicious cycle of fatigue. The weak muscles have to work much harder to breathe, which makes them more tired, which in turn makes breathing even weaker. Especially over the course of the night, ventilatory failure and hypercapnia develops as a result of this condition. Changes of lung volumes in neuromuscular and chest wall disorders. So, what does these lung volumes parameters get affected in neuromuscular and chest wall disorders? So, what happens in scoliosis, what happens in ankylosing spondylitis, simple obesity, OHS and chronic neuromuscular conditions. So, changes of lung volume in neuromuscular and chest wall disorders. Scoliosis, the TLC is significantly reduced, both FRC and residual volume are also decreased because the entire chest cavity is smaller and cannot expand fully. So, this is a classic example of restrictive lung disease. In ankylosing spondylitis, it is a reduced total lung capacity. So, it is a restriction. It has a unique effect on functional residual capacity. The chest is often fixed in an inspiratory position. So, the patient will be like this. Inspiration is completely full, leading to a relatively high FRC and residual volume compared to the overall small lung capacity. In simple obesity, it leads to dramatically reduced functional residual capacity. The lungs are squashed as the tummy is pushing the lungs up. So, at the end of a normal breath, however, the total lung capacity may be near normal because a person can still use their muscles to take a deep breath. Then obesity hypoventilation syndrome. This is a more severe condition than simple obesity. So, in addition to the compression effect causing a very low FRC, OHS also involves blunted drive to breathe. So, the breathing drive will be also affected in OHS. This leads to reduction in TLC as well, creating a restrictive pattern on top of the obesity. Then chronic neuromuscular diseases, conditions like ALS or muscular dystrophy, which weakens the respiratory muscles. This weakness make it difficult to take a deep breathing, causing a reduced TLC. It can also make it hard to force the air out, so which can sometimes lead to relatively normal or even slightly increased residual volume. As a proportion of the smaller TLC, the FRC is also reduced. So, these are the diagrammatic picture. Here we see total lung capacity, FRC and residual volume and the changes according to the different conditions as discussed earlier. Now, we are going the indication for non-invasive ventilation, that is positive pressure ventilation in a restrictive chest wall and neuromuscular neuromuscular and chest wall disorders. Now we are going for indication of NIV use in a restrictive chest wall and neuromuscular disease. So there should be a symptom of hypoventilation, that is morning headache, daytime sleepiness, and one of the following: either the carbon dioxide level should be more than 45 millimeter of mercury in an ABG during a daytime, and there will be decrease in saturation in less than 88% or more than or equal to for 5 minutes. So 5 minutes decrease in saturation during the night. In case of neuromuscular diseases, the FVC is also should be looked. The FVC is less than 50% of predicted, and the mean inspiratory pressure is also reduced, that is less than 60 centimeter of water. So we are coming to the conclusion of the hypercapnic central sleep apnea and hypoventilation syndromes. So during the sleep, so all the major factors like arousal from sleep, NREM, wakefulness drive, medulla, carotid body, so these all finally act on one particular system, is this ventilatory pattern generators. So this ventilatory pattern generator is the most important part, which is associated for a control of respiration during sleep. So what happens? The conditions like idiopathic central hypoventilation, brain tumor or CVA, these will affect these centers directly. The sedatives, narcotics, these will affect the medulla. So medulla subsequently will affect this ventilatory pattern generators. So these will be from the central side. Now coming to the transit. So the supply. Conditions like polio, amyotrophic lateral sclerosis, phrenic nerve injury, myasthenia gravis. So these will be affecting the neurons or the sensory system. Then the muscles, which is the important part in respiration. So conditions like myopathy, which affects the muscles. And the next one will be the lungs. So lungs and chest wall. So rib cage. Kyphoscoliosis will affect in this stage. So along with this, the primary component for all those things will be the PCO2 level. PCO2 level increases or decreases during the night time will lead to central sleep apnea. This is just the pathology is different. Now we are coming to the conclusion part. So we are going to see some interesting cases from each conditions. We will be looking in the history, then investigations, graph, and coming to the diagnosis. In the history, we see a 55-year-old male, a normal weight, complains of frequent awakenings, gasping, and severe daytime fatigue. So his wife notes he stops breathing for a period, followed by a few large gasping. Then another pause. So the patient doesn't have any heart failure, no opioid use or no neurological conditions. We done a polysomnography which shows the AHI of more than 40 events per hour. Over 90% are central apneas occurring mainly in NREM sleep and often following brief arousal. So what are the clue? Patient is normal weight, no heart failure, no opioid use, no neurological disorders. AHI more than 40, all are central sleep apneas and NREM sleep. And the important point, the daytime PCO2 is slightly low. So this is the graph of a polysomnography of this patient. So looking into the graph, what we can tell, there is an hyperventilation followed by a cessation in breathing. So coming to the diagnosis, what can be the diagnosis? It is idiopathic central sleep apnea. So what we should look is, we should not ignore that non-obese patients will not have sleep apneas. So we should look for central sleep apneas in non-obese patient. Usually we suspect OSA or obstructive sleep apnea in obese individuals, but central sleep apnea is common in non-obese patients with classic sleep apnea symptoms, no other clear medical causes, and their problem is of the control, not with the obstruction. Moving to the next case. Now we are going to the case study 2. A 72-year-old male with a history of congestive heart failure. The ejection fraction is 30%. Complaints of poor sleep, waking up feeling shortly of breath, and daytime sleepiness. The investigations reveal a cyclical breathing pattern with a cycle length of 60 seconds. The tracing shows a gradual increase, then decrease in breathing effort and airflow. What does this show? Gradual increase, gradual decrease, followed by a 20-second central apnea. So already we might have guessed the condition, waxing and waning. So this is a polysomnographic graph. So waxing and waning, that is chain stroke breathing. So this is a chain stroke breathing associated central sleep apnea secondary to congestive heart failure. Clinical pulse, a long respiratory cycle time that is more than 45 seconds on a sleep study is a strong clue for cardiac etiology. Why a long respiratory cycle time? Because the major pathology here is delay in circulation. Reflecting a prolonged circulation time. Now we are moving to the case study 3. A 48-year-old female on long-term methadone and oxycodone for chronic back pain. So here the history is opiates use. Her partner is concerned because her breathing at night is slow and sometimes stops altogether. So here she has a nighttime decrease in breathing and sometimes cessation. She is very sleepy during the daytime. So the patient was further investigated for polysomnography, which shows a low average respiratory rate, periods of ataxia, that is irregular breathing, and frequent central apneas. Her daytime carbon dioxide CO2 level is highly elevated, that is 52 millimeter of mercury. The normal range is 35 to 45, confirming it is an hypercapnia. So we did a polysomnography. We found what? The saturation, the carbon dioxide CO2 levels will be high, ET CO2 level will be high of 52 to 54. Then there will be decreased respiratory rate. So altogether it is a picture of hypercapnic central sleep apnea due to opioid use. The clinical pearl is always take a detailed medical history. Sometimes the patient will miss the history of using any other medications. So opioids are a potent and increasingly common cause of central sleep apnea. The fourth case here is a 60-year-old obese. So here comes the obese, a male diagnosed with severe obstructive sleep apnea. So the patient is already diagnosed with the OSA, severe OSA. So that is severe OSA, AHI of more of 65, mostly of obstructive event. So first polysomnography we saw it as a obstructive event. Then we started the patient on CPAP titration study. at a pressure of 12 centimeter, all his obstructive events and snorings are eliminated. So the patient is improving. But what happen is, the due course, despite now the open airway, he continues to have a respiratory events. That is, the polygramophy shows a central apneas with an AHI remaining at 35. So what we saw, this obstruction was unmasked the central apneas. This is a picture of complex sleep apnea. We started on CPAP, then the patient is showing a central sleep apnea. So the diagnosis is complex sleep apnea. So when a PAP therapy is initiated, we are not just to stop with the PAP therapy. Don't assume that everything is over. So we should look for a titration study. We should look periodically how the patient is performing, how the quality of sleep has improved. So here the PAP therapy is improved the obstruction, but it just shows the central apneas. So review the device data and perform a repeat study to see the type of residual events. Coming to the last case, a 65-year-old male with amyotrophic lateral sclerosis. So it is a neuromuscular disease. Okay, experiencing morning headache, daytime fatigue and disrupted sleep. Pulmonary function is FVC is 45% of predicted, indicating significant respiratory muscle weakness. On polysomnography, shows a prolonged periods of shallow breathing, that is hypoventilation, with significant decrease in oxygen saturation, especially during REM sleep. Some discrete central apneas are noted. His EtCO2 is consistently elevated. EtCO2 is consistently elevated. So here you can see the EtCO2 is elevated, shallow breathing, decreased chest movement. So all together the problem is with the neuromuscular disorders. So it is a hypercapnic central sleep apnea or sleep related hypoventilation syndrome secondary to neuromuscular disease. So morning headaches are the red flag for overnight hypercapnia and should prompt an investigation into respiratory muscle strength and nocturnal ventilation. So with this, now we are going to conclude. Now we are going to see the summary of the complete presentation. So what we have saw, central sleep apnea is a diverse group of disorders caused by a failure of the brain to signal the body to breathe properly during the sleep. So it is broadly classified into hypocapnic and hypercapnic. In hypocapnic, unstable control, low or normal CO2, which is a problem of overreaction, and in hypercapnic, which is a problem of under breathing. Okay, in hypocapnic we saw idiopathic central sleep apnea, chain stroke breathing associated central sleep apnea, high altitude periodic breathing, complex sleep apneas, and also driven by high sensitivity to carbon dioxide level and the apneic threshold phenomenon, leading to an oscillatory pattern of breathing. In hypercapnic, which are driven by a blunted respiratory drive, that is won't breathe, or a respiratory pump failure, patient unable to breathe, leading to sustained low ventilation. The underlying cause explains the pathophysiology and a crucial role for determining the correct diagnosis. So when we diagnose the condition correctly, it is easy for us to treat, because the underlying cause should be treated always for better improvement. So treating these different conditions requires vastly different approaches, and an accurate diagnosis is the key for an effective diagnosis. So in the end, I want to tell, diagnosis is very important in central sleep apneas. So with this, I conclude my presentation. Thank you.